Hello, I'm Dr. Scott Worden, the TOS guy, and welcome to our today's live stream, which is going to deal with how technology and sports and car accidents can affect and cause TOS and the underlying mechanisms to a lesser extent. This talk is called Thoracic Outlet Syndrome in Modern Life, how technology, sports, and car accidents alter anatomy and cause TOS. Here are the three topics we're going to cover: technology, such as our computers and phones and other devices, sports, and motor vehicle accidents. These three are common causes of neurogenic TOS, and neurogenic TOS represents 95 to 98% of all cases of TOS. It's also the most difficult to diagnose. So these are important mechanisms to understand. This is a schematic of the thoracic outlet in which we can see the brachial plexus in yellow, the subclavian artery in red, and the subclavian vein in blue. These are really important structures that come out of the neck or the chest, and they have to pass through a series of tunnels to reach the arm on each side. This is the thoracic outlet. Now, we've seen some of these slides before. I'm going to review some of the anatomy so that we can understand the mechanisms that come up from our modern life. The anterior scalene muscle is an important one to know. Between the anterior and the middle scalene muscles and the first rib, we have the scalene triangle. We'll also notice the collarbone or the clavicle, which moves tremendously with the shoulder, and it can move relative to the first rib, which can create a vice-like effect, crushing or squeezing these three vital structures. This purple triangle shows the scalene triangle. After the subclavian artery and the brachial plexus leave the scalene triangle, they enter the costoclavicular interval between the clavicle and the first rib. And you'll see here the brachial plexus and the subclavian artery leaving the scalene triangle and then joined by the subclavian vein to go through that costoclavicular interval between the collarbone and the rib. This is a view from the side. We'll see the same important structures, the anterior and middle scalene muscles and the first rib. You'll also notice the collarbone, clavicle, that can get farther or closer from the first rib. In purple, we see the scalene triangle. That contains two structures, the subclavian artery and the brachial plexus. And once they enter the costoclavicular interval, this space, you'll see that it's joined by the subclavian vein. So all three structures pass between the collarbone and the rib. The scalene triangle and the costoclavicular interval are the first two triangles or spaces of the thoracic outlet on each side. Again, we're just pointing out the important structures here. Now we move on from the costoclavicular interval to another tunnel behind the pectoralis minor muscle. You'll see I've also pointed to the scapula, the shoulder blade. This is a very important bone. It floats over the back of the chest. It's only attached by 17 muscles that can pull in many different directions, and then one bone, the collarbone. But it has a huge freedom of motion in many different directions. And behind it, you see the arrow and the circle. We see these three important structures, the brachial plexus, subclavian artery, and subclavian vein pass through this retro, meaning behind, pectoralis space. There are reasons why the three structures can get compressed or stretched in this space. And we see again, these structures are labeled subclavian artery, subclavian vein, brachial plexus. Let's move on. Let's talk about our first subject, technology. We're going to cover devices that we use every day, not all technology, but we're going to split it by size: desktop computers, laptop computers, tablets, and phones. It'll be a basic structure from which we can work. Desktop computers. I'm sure everybody has a desk that looks just like this: a few books, a few plants, a simple keyboard and a monitor, a cup of what looks like hot chocolate with whipped cream on top of it, and of course, no papers, a picture of your bride on it. Perhaps you have beautiful sunlight coming in like this. This is what all of our desks look like, just about. Except I'll attest to it. This is not what my desk looks like. And this is not what my desk looks like with all these fancy backlighting, the headphones hanging there, just waiting to listen to Beethoven or Nirvana. Who knows? And then, of course, everybody has a $2,000 ergonomic chair, which holds your body in near weightlessness. This one comes with racing stripes. Okay. You'll also notice that when you see pictures of people at work with their desktop computers, they're focused like this young woman, and they're happy like this young woman, and that means they're productive. Okay. But, maybe it doesn't work for everybody. So companies have had to invest in ergonomics. And don't look at the details too much here, except for a few things. Notice that your head, or this person's head, is pretty much straight on. They might look straight ahead to slightly down to see a big monitor. And their hands are at a separate point, different from the monitor where their eyes are. Their wrists are gently slightly extended or slightly flexed, not a big difference. Their elbows aren't bent too much. The posture of their back is great. And off to the right, you see a coffee cup that says, take breaks every 25 minutes. I'm pretty sure that all of us have a boss who comes to us every 20 minutes and says, make sure you take that break in 5. Here's just another example with a little more detail about how ergonomics can be highly variable. Now, this looks a little bit more like me, although I don't have a mustache. I'm leaning forward because the monitor may be too small or my eyes aren't so good. Or I'm stressed because of work and I got to get this work done, so I'm racing to get it done. My hands are crunched up a little bit. My elbows are bent too much. My back is not against the lumbar support of my space chair. And you can see what results from this sort of thing. In the end, this might look a little closer to me on a normal day, until that voice inside my head says, Thoracic Outlet Syndrome. Come on, Scott, pay attention. So we're all at risk for that. So people have come up with various ergonomic devices and reminders. Here's one that actually I have. I have a standing desk. It can go up and down so that another health risk we haven't talked about, sitting too long, can be alleviated to some extent. And this now solves all of our problems. You'll notice the metallic arms, and you can put everything at different angles. What they don't explain in this picture is how you would use the keyboard of that laptop, but it looks great, right? And here's a productive worker happily standing at his standing desk. Everything is adjusted perfectly. His hands are down, his eyes are up. He doesn't even need that chair until he takes a break, and then he works while sitting for a while. And here's a guy who's perfectly ergonomic, except for, with all that ergonomics, he's using his phone the wrong way. Okay, here's some more details, how we make even the stand-up desk ergonomic. Here's another person, happy and productive, using her ergonomic desktop. And again, I would question how she would use that laptop in such a position, but they don't make these pictures for critics like me. So let's move on to laptop computers. Now, laptops have several problems. This woman, of course, is having no problem at all. Again, she's happy and productive in a beautiful leather chair. Everything's great for her. And this woman is even happier, I would venture to say, all working on a laptop. Turns out when you look for pictures of workers using laptops, you find a lot more like this. Everybody's happy, of course, but no one really has their hands on it with rare exceptions. They're all doing something else with their hand, holding a cell phone, smiling, drinking a cup of coffee, because of the problems that we have with laptops. This one came from an article in the New York Times talking about a huge amount, a pandemic of work-related injuries because people are working from home. Now, she's got that cup of tea and she's got a phone near her. She's sitting in a happy position with her laptop. Of course, she's not using the trackpad. And I don't know how she can see the screen from there, but picture looks good, right? And this woman looks even happier. I've tried this position. I'm sure any of you who know yoga have probably tried this position, but I don't think you can use it for long. And I don't think it helps your arms or your neck or your eyes work much more productively. But she's happy, and that's what's important. So let's look at some of the ergonomic issues with laptop computers. Number one, keyboard spacing. The keys are almost invariably smaller and closer together. And oftentimes you need to use two hands to hold modifier keys because all the keys aren't there. Most laptops of any reasonably small and portable size don't have a numeric keypad either. So reaching to the top row for function keys or number keys is harder. Secondly, the monitor placement. Monitor cannot be up by your eyes if you want your hands in good position. And if you want your hands in good position, well, the monitor is just down right where your knuckles are. It's not good for you. You can't get your neck and your arms and your shoulders into the right position no matter what you do. The monitor size is almost always smaller than a desktop monitor. That's a problem for a number of reasons. You have to get closer to it. So like me, you might lean into it to see the smaller things. And finally, the size of the control surface. You don't have a mouse that you run over a big mouse pad. You have a tiny little trackpad. Maybe like on the ThinkPad, the IBM computers, you have a little red plastic thing in the middle you can move. But they're all very small, and so it forces you into a position just to use the control surface or to use the keys or to look at the monitor that is not ergonomic. Okay, now some people have tried to overcome this. I don't know if any of you have ever tried a device like this. The man looks reasonably happy. I personally wouldn't be working like this. It's still a little weird, and still his eyes and his hands are too close together. This is even weirder to me. She's got her hand on a mouse way out there. That can't possibly be good. Now, unfortunately, she's not smiling. I think she probably didn't get hired for the next modeling gig for this. This woman is smiling, though, and she's got a great device. She's happy. She's laying down or she's sitting. But again, it has all of the same basic issues. She's not supported. Her back is not supported. Her neck is not supported in any of these. And her eyes and her hands are too close together. You can't find one of these positions where she's comfortable, except where she's sitting on the bed, leaning back against the headboard, and she's not using her computer. So ergonomics improves sitting posture. Here we see a nice example. The keyboard is tilted up. All right. Is everything fixed? Well, the lumbar spine is better. The eyes and the position of the head are better. But look at the hands in the photo. I mean, that's not comfortable. Number one, the wrist shouldn't be extended that much. Number two, if you've ever tried typing while reaching out way in front of you, it's not fun. Now, this woman, again, happy and productive, very happy. But is she going to use that laptop like that? If any of you have ever tried it, and I have, it stinks. There's no way to use it like that. It's not comfortable for very long. I mean, a minute you'll be uncomfortable, and I couldn't type for anything with it like that. So let's move on now to tablets. Surely tablets must be better than these other ones. This woman looks happy, right? I don't know if she's at work or just enjoying her day. And this woman looks happy. She's probably not at work. That's my best guess. But those positions are not very ergonomic. And now the ergonomic positions and issues with tablets are even greater than laptops. They're exaggerations of it. Number one, you usually need to use a hand to hold the tablet. That means you only got one hand to interact with it. You're going to get tremendous imbalance that way. And by always holding the tablet, you just have constant weight on that arm. It's going to affect the entire posture of your arm, shoulder, and neck by trying to hold even a small tablet. Number two, the monitor and the control surface overlap. You couldn't get a worse situation to use your eyes and hands separately. As everybody knows from using a tablet, your hands are there, then your eyes are there. The monitor size is smaller than a laptop. That's a problem. You'll be squinting, you'll be bending forward to see it, or you'll have to raise your arms up close to your face. That's not going to last for long either. And finally, the control surface size, depending on what you're doing, obviously there's some flexibility in those screens, but if you're typing or trying to move a cursor, it's a pain. It's even smaller than the trackpad on a laptop. So, of course, people have come up with ergonomic devices. This looks awesome, right? Or how about this one? Except, have you ever tried to write in this position? Have you ever tried to tap on the screen? You'll notice she's not doing that. It's almost impossible to do it for any period of time. Unless you're very flexible, you can't lay on your stomach, arch your back, arch your neck, get your head up, get your arms free, and use that tablet for what you're supposed to use it for. This is bad positioning. Now, you could go and buy an expensive weighted device like this with all these elements to help position the laptop. And then you have a separate keyboard, but then this is not really using a laptop. You need a separate mouse, a separate keyboard, and this just works like a small monitor. And again, because it's small, you're going to lean forward and you're going to ruin your posture like that, just like your mom used to tell you before there were tablets. So phones. All right. Here's a nice picture. Woman on the left, same woman in all three pictures. She's in good position. I don't know how many of you hold your phone like this, but you don't do it for long, I would bet. You much more look like the same girl in the middle. And then after a few minutes, the same girl on the far right. That's how we all react to our phones. There's a neat little picture just from left to right showing the amount of force on the neck. Don't worry about those numbers, but I think we all look like this, except the hand doesn't stay there. As the neck droops, the hand droops, and I think we all do that. Just another example from a website. Before, neck strain, rounded shoulders, back strain. This is from an orthopedic website. I'm sorry, physical therapy website. But afterwards, after the physical therapist says, hey, you should be doing it differently, she's in a great position. No strain of her back, no strain of her neck, and neutral position. Again, I would ask you though, do you ever use your phone like this for more than 2 or 3 minutes? Let's move on to sports. Okay, in general, we deal with overhead athletes, and usually overhead athletes who generate a lot of force while their arm is in the overhead position. Think about a volleyball player spiking the ball. Think about a swimmer taking that huge leap forward for that big stroke they need to take. You can see several of these sports listed: swimming, diving, water polo, of course, rowing, volleyball. But the last one, baseball, is where we're going to focus for the purposes of this talk. This is an example of the basic knowledge and the basic positions of a pitch. The windup, you can see that both hands go backwards. The pitcher's looking at the plate, picking up his front leg. Early cocking, when you start cocking it like a rifle, ready to shoot the bullet out. Late cocking is when you move your body forward, storing all that energy in the shoulder and arm so that you can propel the ball and accelerate in the next phase. And then you have a follow through. Now that one late cocking picture looks kind of uncomfortable if you had to hold it. This is a view from the top down, and you can see in the picture to the right what that looks like when you get into that late cocking position. The body is moving forward, storing all the energy and allowing it to release in the shoulder and the arm. It doesn't look very natural like that. And if you look at still pictures of a major league pitcher, the windup is on the left, early cocking, second picture. The third picture is the late cocking and then acceleration and follow through in the last picture. That third picture doesn't look all that comfortable. The neck is going one way, the shoulder and arm are going another way. There's a huge amount of what we call external rotation. Pitcher from the Mets, unfortunately my team. It's been tough to be a Mets fan, but take what you get. And again, that looks like tremendous strain on the entire arm and shoulder. Elbows go out in pitchers frequently. This is one I want to show you. It'll take 30 seconds. And we're going to look at a super slow motion. Zach Greinke was an excellent pitcher, still is. He was on the Kansas City Royals. This is cocking and wind up. I'm sorry, this is wind up. It's going into early cocking where the arm starts holding back relative to the body. Early cocking. Remember, it's like cocking a rifle for a shot. When his foot touches down, his body goes forward. This is late cocking. Look at that position. Oops, sorry. I'll play it again for you. Don't have much control over these. I'm going to see if I can pause it at the right minute. Okay. Early cocking, not too bad. Stepping forward, winding up that body. Late cocking. Look at the difference between the neck and the shoulder and the arm, and it gets worse. Look at it there. Now he's just about to accelerate, release the ball. That looks like a tremendous amount of stress on everything there. And there's acceleration and follow through. I think these slow motion, super slow motion pictures are just amazing. Okay. Let's take a look at this. This is you can see the brachial plexus, subclavian artery, subclavian vein, what we call the neurovascular bundle. It's leaving the scalene triangle. It's going between the rib and the clavicle. And then that muscle to the left is called the pectoralis minor. And this is the retropectoralis space. So look what happens when you raise your arm. You're putting tension on the neurovascular bundle components. You particularly could be stretching them against that bone called the coracoid process at the top of the pectoralis minor. And this doesn't even look as bad as what that picture was just doing. So there's a lot of wear and tear on the brachial plexus in this space. Baseball pitchers, third basemen who have to throw a lot, they more commonly get TOS. There are some big names on this list, including Steven Strasburg, who used to throw 100 miles an hour regularly. Matt Harvey, who was a Mets pitcher and unfortunately developed TOS. J.R. Richards, who was famous with the Astros in 1980, had to retire because of strokes he got from TOS. It's uncommon in basketball players. There are two recently who have been found to have it. At least that's what their publicists say. And Markel, sorry, that should be Markel faults. Anyway, there are exceptions because, we believe maybe they don't have to generate as much force when their arms are in these vulnerable positions. Also, their arms tend to be in front of them instead of behind the shoulder, as you might guess in swimmers, and as you can see in baseball pitchers. All right, so I'm going to move on to our last general topic, motor vehicle accidents. I'm going to start, what should be a video here, 6 miles an hour. Okay, coming up, there's a truck hitting this woman at 6 miles an hour. Not too bad. And that's the regular, well, it's slowed down a bit, right? But we're going to show it again in super slow motion. Watch her head and neck. Okay, I'm going to go back just a bit because it's dramatic. Okay, let's go back to the beginning of the slow motion, super slow motion. Sorry. Okay, super slow motion. Look at the head and neck. Even her jaw opens up. Okay, and this is at 6 miles an hour. Now, the cervical spine has a ton of ligaments. I don't think it's important to know the names. You can see that there's intervertebral discs, and they have ligaments at the front and back. There's a whole bunch of things that hold the neck together. Just a different picture of all these various structures that allow you mobility. They allow you the strength to bear the weight of your head up on top. And they also hold things together. And these can all be injured in whiplash or injury mechanisms that are the same. Just another picture of all these ligaments. But also remember, we have a ton of muscles. Bones would collapse pretty quickly if you didn't have muscles. Bones are very strong, but the muscles modulate and balance all of these forces and stresses that we get. So what happens is when you have that kind of an action, here we're looking at the anterior scalene muscles. These are some of the biggest muscles that contribute to stabilizing the neck. And when their force is enough to hold the neck in place, that's fine. But when the force is greater than the force that they can generate, they will tear. They get micro tears, they get scarring, they become stiff and short. If they're irritated, they become short. If they scar down, they become short, and your neck starts leaning forward. And that allows them to collapse and shorten even further. It's a bad cycle that we know occurs in TOS patients. Once patients get rounded shoulders and lean their head forward, it puts those scalenes at risk of assuming a shortened length for a long time unless you break the cycle. Anterior scalene here, and you can see the scalene triangle will show up in purple. Right there. This is one of the areas through which the brachial plexus and the blood vessels have to pass. Only the subclavian artery, by the way. Subclavian vein doesn't pass through the scalene triangle. Okay. So we've covered our basic topics. I'm going to close out of this talk. And now if there are any questions, I'm going to be happy to take those questions. I'm going to go back here. I'm going to stop sharing my screen. And here I am. So hopefully everybody has stuck through that and learned a little something, and it's brought up a few questions, and we'll take the questions as they come in. All right, Herm. Let's see if we got anybody who wants to ask about those various topics that I brought up, or if they have questions about TOS in general, or you can ask questions about our MRI. All right. KKC 2019. Dear Dr. Worden, thank you for sharing these useful videos on YouTube. Thank you. They're very informative and helpful. Well, I appreciate the compliments. Of course, we work hard here to get this done. And we hope that you'll help spread the word. We believe that awareness of TOS is critical. There's so many patients out there who suffer these kinds of injuries. And when they search for neck pain or shoulder pain on Google, they get 10 million choices. It's not up to the patient to figure out which one of those is correct. So we believe that TOS is a unique entity and we need to help people find it. So follow us on Instagram and YouTube and Facebook and help spread the word. That's the best thing we can do for people. All right. Lewis Bennett says, I heard you mention some basketball player getting strokes from TOS. Forgive me if I said it that way. Lewis is a baseball player by the name of J.R. Richards. He was a very imposing 6'6" tall pitcher for the Houston Astros in the 1980s. He won Rookie of the Year, and he was kind of like another Nolan Ryan. The guy was a fireballer. He was very intimidating, and Rookie of the Year, and he was on the All-Star team his first year. It was his second year, I believe, where he started showing up with a tired arm, and he kept telling the trainers and the team doctor he didn't feel right. And they just said, just tough it out. You're a guy, tough it out. And then he had a stroke and the game was up. Turns out he had venous thoracic outlet syndrome, meaning blood clots in his subclavian vein. And unfortunately, it was a rare case where they went up the arteries to the brain and they caused a stroke, and he was never able to play again. He died a couple of months ago. His obituary was in the New York Times, and, it's kind of sad because he had all this promise. Thank you for the question. All right, KK says, I had surgery 6 months ago and got a cervical rib and fibrous band removed and the nerves decompressed. I have 2 questions. Will my hand muscles come back and fingers strengthen eventually? Number 1, that's going to depend. I can't, through this medium, give out specific medical advice. So I will talk in generalities that cover part of what you're asking. And please give me forbearance for that. The test that's most important in this case would have been an EMG, or a nerve conduction velocity. If you had that test ahead of your surgery and it was negative, then there's a better chance of nerves regenerating. In specific, when we look at entrapment neuropathies, where a nerve going through the body, it could be the elbow, the leg, the foot, when it gets trapped, stretched, or squeezed, we try to treat it before we get motor abnormalities or muscle abnormalities. And once the motor nerves, or the nerves that go to the muscles, get damaged, it's harder for them to recover, less likely percentage-wise. If just the sensory nerves are damaged, like the nerves that you can feel touch or position or a pinprick, if just those nerves are damaged, they're more likely to return and gain function. So the important thing is, if your doctor's operated to prevent future loss of muscle function and grip weakness, and then at this point, you'd have to wait and see how much would come back. Again, an EMG or nerve conduction velocity test may help in that situation. You had a second question. Number 2, I would like to get back into weightlifting exercises and gain a little bit of body weight. If I start working out again, will my TOS problem come back? Thank you. Thank you for the question. So again, I can't be too specific. This is something you should work on with your physical therapists. They're going to be the ones who judge your body coordination, strength, etc. And I think working through a steady program, you should certainly regain or have a chance to regain, a lot of athletic ability because the underlying problem has been treated. Without imaging, without any of your detailed history that we doctors like to share all those big words, I can't specifically tell you what the risks are or how much you might recover. But, imaging can be helpful in that regard to see after surgery how much space you have there, whether the nerves are inflamed, if there's any residual or developing scar tissue, things like that. So while I can't answer your question specifically, hopefully I've given you the idea. But if you contact us through our website, tosmri.com, go to our contact page, we'll try to help you more specific in private with, protected HIPAA security. So we'll try to help. Thank you. All right, let's see what we got next. Lewis says, I heard you mention an athlete that got a stroke. What's the mechanism of how this works? So strokes are somewhat uncommon, actually very uncommon in TOS patients. Let's talk quickly about the 3 types of TOS. There's neurogenic, by far the most common type. 95% of all cases of TOS are neurogenic, and it's hard to diagnose. It's where the nerves get compressed in various degrees and various combinations. Arterial TOS is quite rare, about 1% of all cases. And that's where compression of the artery over and over eventually causes damage to the arterial wall. It's been found that when the blood goes through the artery at a very specific velocity, it creates damage to the wall, just distal to that. And so the artery can swell up, the wall can weaken, and it forms an aneurysm, or a balloon-like dilation. Blood clots can form in that. Now, when blood clots form in this abnormal part of the artery, they can break off and go distally down the arm to the elbow, to the forearm, to the fingers. And if they block enough blood flow, it's a surgical emergency. You have to remove those clots and get the blood flow going again, or that tissue will die. But rarely the blood clot can go retrograde, meaning backwards from the blood flow, or the blood clot can grow enough to peak backwards into one of the arteries to the brain. And if it breaks off and goes to the artery in the brain, it causes a stroke of various sizes. In another situation, there can be a small asymptomatic hole in the heart. And if you have a blood clot in the subclavian veins, this is venous TOS, that blood clot can break off. Sometimes it goes to the lungs. Rarely it can go through this defect in the heart and then cross to the arterial side. And from the arterial side, it may go to a leg or to an arm or to the brain. If it goes to the brain, it forms a stroke. I hope that answers your question, Louis. Thank you. Rosalie, hi. Are blood clots a cause or an effect of TOS? That's a great question. They are an effect. They cause symptoms, but there is an underlying mechanism that starts with this compression or tension, with the spaces being too narrowed. And then either the artery or the vein, as we were just talking about, gets damaged. And when it's damaged enough, a vein will have some internal lining, won't be smooth enough, and a blood clot will form. And an artery will get this damage where usually it swells up like a balloon, what we call an aneurysm, although at other times it can form a web or a stenosis, a narrowing. So either an aneurysm or a stenosis forms in the artery and a blood clot forms there. And if you're talking venous thoracic outlet syndrome, when you damage that vein enough, what's called the endothelium, the lining, which prevents blood clots from forming through biochemical methods, when that endothelium breaks down, a blood clot can form, and it can slow down flow from the whole arm. The arm can swell up. It can become purple. You can find new veins forming that allow blood to get around that blockage. Again, to answer your question, blood clots occur as a result of all these findings, and then blood clots cause the symptoms. Thank you for the good question. All right. Let's see what other questions we have here. Trying to make sure we allow enough time for them to come through. I'm going to take a look at my calendar also to tell you when the next TOS talk should be, and I believe it should be, see, we're on February 15th now. Our next one definitely scheduled, I believe, is March 29th. We're checking on that. That's a special one because we're going to have myself and Dr. Art Jenkins go over a couple of cases we've worked on together. We're going to show the data like the imaging, and we're going to discuss how we considered the case, how we came up with the answers we got, and what the results were of treatment. There we go, March 29th. Case studies. TOS experts discuss 3 interesting cases. All right, that'll be a really good one because you can see how doctors think about this, how we share ideas, how we communicate, and how we try to solve these problems to come up with a diagnosis, to confirm the diagnosis, and to consider the best treatment choices. Lewis asks, can you have arterial TOS in the pectorals and scalenes at the same time? So that's a really good question. The classic form of arterial TOS actually occurs just beyond the costoclavicular interval. It doesn't usually occur where the scalene triangle is. Just a little distal to the scalene triangle is the costoclavicular space, where the first rib holds tight and the collarbone can come down on top of it repeatedly. That's where you would think the damage would occur. But it turns out that a very famous doctor called Halstead at Johns Hopkins, he had found cases of subclavian artery aneurysm, and he tried to reproduce them by taking dogs and putting a band, a metal band around their aorta, the big artery in your abdomen and chest. And he tried to cause formation of subclavian artery aneurysms, or in this case, aortic aneurysms. And it was very difficult, he found. He had some of the dogs that showed up with aneurysms distal to that metallic band. Turns out many years later, I think in the 1960s, a different doctor came up and found that the blood flow had to be within a very narrow range of speed and have a certain harmonics and create a certain amount of turbulence. And it was just the right velocity and just the right turbulence, then the walls would get damaged distal to the compression, and you would get this aneurysm forming. So just beyond the first rib is where most subclavian artery aneurysms form, to the best of my knowledge, but it's really in a narrow area. But there are some unusual ones. There was a baseball pitcher, he's probably in the press, but I won't mention a name. And he developed an aneurysm out here, what's called the circumflex humeral artery. So as you do this with your arm and you get it really tremendously stressed backwards, there's a ring of arteries around the upper arm. And I suppose over time, there's never been any research to prove this, there was too much tension on that ring of arteries. It kept pulling and pulling. You had an artery coming in, you had this circle, and eventually with enough pulling, you damaged the wall and you got this aneurysm. And the aneurysm, this arterial sac, had to be removed and the blood flow in the artery maintained. So that's an unusual location, but yes, that does occur in baseball pitchers. So I think the most common location is on the first rib or just past the first rib. The retropectoralis space, really, I haven't seen one there. I presume it's possible. And then out at the upper arm bone is where I've seen a few rare cases of it. All right. This is our next question. All right, Herb, do we have any other questions you would like to put up? KK again, thank you for answering my questions. You're welcome. Any diet or specific foods that I can eat to support my post-op recovery and accelerate nerve regeneration, axon improvement, and conductivity? Thank you. You're probably asking the wrong person since I don't handle most post-op patients. I don't handle recovering nerve injuries. I think if you have your surgeon, if he or she is comfortable. I think if you have a neurologist that you're seeing for this, I think those are the people to ask. Certainly it doesn't hurt to consult a well-read nutritionist who deals with these type of injuries. I personally try to follow, when I have some willpower, an anti-inflammatory diet. And so I think the jury is out on that. But certainly some of our TOS patients follow a strict anti-inflammatory diet and believe that it helps. I'm not aware of literature specifically linking an anti-inflammatory diet like salmon and all those things that are good for you, olive oil, the Mediterranean diet, to improvement in TOS. I don't think there's any research. So I'm sorry, I can't really answer that question for you. It's just not my field. All right. So I want to thank everybody for attending and thank everybody who watches this in the future, because we save our live streams and we put them up on our YouTube channels. Again, I want to thank toseducation.org for sponsoring these and producing them. Oh, wait. I got another question. I love these questions. Lewis says, what do you recommend a patient does when your physician is clueless on TOS? When your own recommendations for treatment based off more recent research is better than what the doctor recommends? Okay, so Lewis wants to put me in a tough position, and I hope it's not a doctor that I know. So we deal with lots of doctors around the country, Lewis, of varying degrees of knowledge about TOS. And I want to be clear here. There's tons of stuff I don't know. There's tons of stuff that any doctor doesn't know. So one of the keys is to be able to say, at least for me, this is out of my field. Like the last great question from KK, I can't help with the best way to manage a diet and healthy lifestyle going forward. It's not my field. So we do see doctors who don't know much about TOS. And a lot of those doctors will refer them to me or to other doctors that I work with who are TOS specialists. That's great. Get the patient to somebody who knows. Now, suppose that TOS specialist says to the first doc, yeah, I saw your patient, John Smith, and I don't think it's TOS. Great. Now the patient goes a different direction to get a diagnosis. But let's say the TOS specialist does say it's TOS, then the patient is in the right place. Now, we also get docs who don't know a lot about TOS. Stuff lots of docs don't know about. TOS, unfortunately, has a stigma I've talked about before from the 1980s, where a doctor did EMGs or nerve conduction tests on a bunch of patients with the purported diagnosis of TOS. And by the way, that diagnosis is not guaranteed. There is no clinical 100% diagnosis. But he took a bunch of patients who had been given that diagnosis. He did EMGs, and he said, here's what I get. A few of these patients have EMG abnormalities. Okay, those are true neurogenic TOS. I'll accept that. The other patients have all the same symptoms, but they don't have positive EMGs. And they also don't have wasting of the hand muscles, all right? So I'm going to call those patients disputed neurogenic TOS. Now, he could have said, maybe they are EMG negative, right? But he didn't. He said, I'm just going to call them disputed TOS. And you know what? That word disputed is terrible, right? It says that, yeah, it's voodoo, it's superstition. It's not disputed. Today, there's 3,000 papers out there floating around in peer-reviewed journals about TOS. So some docs, unfortunately, said, I don't need to learn about this disease. It's disputed. It's voodoo, whatever. I dealt with a patient this week who was saying his doctor kind of rolled his eyes at it. And so if those docs don't even try to learn about TOS, then they're never going to see it. You know, there are things until someone teaches me, when you look at the stars, how do you find Jupiter and Saturn? I had a phone app that showed me, and I'm like, wow, they're big. I can actually see them with my naked eye. But if I didn't learn that, if I didn't open my mind enough to see it, I never would have known. I would have thought those were stars. So you have to advocate for yourself is the end result of that. You can contact us. We're glad to connect you with TOS specialists around the country. We're glad to give you information that can help you both about your particular case and to learn more about TOS. And you have to advocate for yourself. You have to be strong. Be polite to your doctor. Don't say, why are you being such a nincompoop? You know, hopefully your doctor will be your ally if you come up with enough information. But if not, you are responsible for your own health and your own well-being. So advocate for yourself and contact us. We can help you with that. Deb says, what are the chances of neurogenic TOS with repetitive work? I've been working as a recreational therapist for 37 years. I am 6 foot tall. I'm 6 feet pushing low wheelchairs. I think that means 6 feet tall. Constant shoulder compression for the last 37 years. So Deb, great question, which I could go into at length, but let's say this. Anybody in an unusual posture repeatedly at work with our upper extremities, from a UPS worker carting things up high in the shelves of their truck to carrying heavy things, to people with non-ergonomic setups at work, to people like sonographers who have to control the dials with one hand and lean over the patient with a probe on the other hand all day long. Or your situation where you're very tall and you're pushing these low center of gravity wheelchairs, you are at risk for developing neurogenic TOS. And you should see or speak to a specialist in neurogenic TOS. Again, contact us through tosmri.com. There's buttons down at the bottom right, and you can go to the last menu on the right. You contact us. We'll talk to you. We'll hook you up with the right people. We're not selling our scan. If you end up getting our scan, great. But if you don't need it, you don't need it. What we try to do is we try to help everybody who may have TOS learn more about it, know where to go to get help, and then find the help that they deserve. Thanks for the question. And Deb asks again, consistently doing dancing and exercise programs, pestering residents, always walking with residents hanging off your arms. Well, again, applying force to your arms in unusual positions could certainly contribute to making TOS worse or could cause TOS. It's the kind of thing that you need to be assessed by your personal doctor if he or she knows about TOS, or to speak to a specialist who does know about TOS, but certainly it puts you at risk. Any repetitive motion in your upper extremities, especially in unusual positions, and made worse with force or weight, predisposes to TOS. Thank you for the question. Mud and Truck and Hunting. You got to love that username. Mud and Truck and Hunting. If diagnosed correctly in the first place, how successful is a rib resection surgery? And how do you do to prevent complications with scar tissue after surgery causing more issues? All righty. So first thing is, there are many different types of neurogenic TOS and many different causes. If you go back to our YouTube channel and look at one of the recent ones I did about anatomy, I don't remember the date or the name. Forgive me, it's just 2 or 3 back from one that I did. We talked about over the 200 years of thoracic outlet syndrome, there have been about 25 or 26 different published papers with different names for the same kind of phenomenon, but that had different details to it. Either it caused different kinds of symptoms, or different maneuvers, provocative maneuvers would cause symptoms. So doctors named it different things, even though they had read the other papers with the other syndromes in them. And in 1956, a resident, I believe in neurology or physical therapy, or physiatrist, I think, named R.M. Peet, P-E-E-T. He published a paper lumping it all together as thoracic outlet syndrome. Now, in that paper, he said, look, We've seen all these different anatomic causes and all these underlying changes and anomalies that people have. And it's so confusing. So let's call it this one group. Now, when you put it all into one group there, then you're going to have a heterogeneous mix of patients. So what's the cause of TOS in you is what's important. That's where something like an MRI becomes tremendously valuable. There's no doctor in the world, I believe, who can diagnose all the causes of TOS, whether you have them or not. There's a bunch of small structures deep inside the neck. There may be one, there may be more than one. Okay, and it's important to know what they are. You use MRI for everything else under the sun. Okay, even things that are obvious. You have an ACL tear, you get an MRI of the knee. Well, why? Well, the doc wants to see, do you have a discoid meniscus? It's not too common, not uncommon, but it might be different. Do you have a meniscal tear, a collateral ligament tear? Do you have a cartilage injury as well? So there are many things that can go along with an ACL tear. So for a doc just to go in and repair the ACL is not the smartest thing, and most orthopedists won't do that. Even if they examine you and they say, clearly on my exam, you got a torn ACL. They go in, they do an MRI first. Same thing with TOS. First of all, no one even can diagnose TOS 100%. It's in the literature. All of the clinical tests, when they say, hold your arms up, open and close your hands for 3 minutes, none of this is guaranteed. None of this is 100% or close to it. So why not get this imaging, right, which has no radiation, like a CAT scan or an X-ray, and see what all that anatomy is. Secondly, the reason I say all this is because your particular cause of TOS could be the collarbone and the rib coming together. It could be you have an extra muscle called a scalene minimus or a levator scapulae. You could have abnormal position of one shoulder blade and not the other. You could have even spurs in your neck. So to decide on the type of surgery is not so simple. Now, for some docs, they always do a first rib resection. They always do it through the transaxillary approach or the suprascapular approach, whatever. That's what they're comfortable with. And a lot of the literature does not say you should change your surgical technique based on the findings of an MRI. We need that kind of study. There's very little of it out there. There's one paper with poor design from 15, 20 years ago, but no one's really done that sort of thing to say, here are the indicators to go to a different type of surgery. So most surgeons doing this complex surgery will take their favorite approach. Maybe it's not the best approach for you, and we don't know that right now. But I would think that imaging and results from surgery can be combined over time to learn how to do these things. Now, the rest of the question was, how do you prevent complications with scar tissue? Well, scar tissue will form after any surgery. Some patients form more scar tissue than others, but also the extent of the surgery. If the doc has to really go in there and, muck about, I'm not meaning to demean what surgeons do. It's obviously highly sophisticated, but the more work they have to do would tend to increase the risk of scar tissue. And a lot of surgeons hate doing these redos where the patient has had surgery, forms scar tissue, and then a new doc or the same doc have to go back in. So there is no one answer to your question. Imaging can definitely help. And again, contact us. Maybe we can help get you more information. Thank you for the question. Deb says, I have 3 neurologists with 3 different opinions. Exclamation point, 3 of them, one for each neurologist, I guess. All different answers, and no one supports TOS. I have had a rib removed for arterial TOS about a year ago. Thanks for your information. So I don't know that that's a question, but I'm going to take it as a chance to talk a little bit. There is no specific diagnosis of TOS on a clinical exam. Clinical exam is where your doc presses here, looks in your mouth, listens to your heart. That's the clinical exam. Some neurologists just do a standard neurologic exam, which is not enough to find TOS. Some of them know enough to do some TOS tests, like an Adson's test or a Ruse test or a Wright test. But none of those tests has been shown to be accurate or sensitive or specific. So they can indicate and lean towards TOS, but they don't prove it. I think that's in the literature. I think I'm comfortable saying that. Imaging can help, and I'm not saying imaging is 100%. There is no test in medicine that's 100%, but I think the imaging helps tremendously, especially if a good doc has done a good exam looking for TOS. I've seen plenty of cases where my MRI matches with a clinical exam and a few cases where it doesn't. And then the doc and I talk about it and figure out where we could be missing that correlation. That's what good teams do. So I don't know about your different neurologists. I don't know how much training or experience they have in TOS. They may suspect it. Well, in your case, you said none of them suspect TOS. So then if you do believe you have TOS, again, contact us. let us connect you with a real TOS expert who can start to narrow it down for you. The TOS specialists we work with are around the country. Don't let anybody tell you Dr. Worden favors a certain doc. No, I have patients contact us all the time. I'll send them to Dean Donahue in Boston and Art Jenkins in New York and Tracy Newkirk in north of San Francisco and this doc here and that doc there. And Greg Pearl in Texas. So I don't do any work with him. I have nothing to gain or lose, but I know he does a lot of vascular surgery. If patients are in a good position to see him, great, go see him, see a specialist. We try to connect with every TOS doctor we know. We try to learn from them. We try to communicate. We try to say, you can use our test if you want because we believe in our test, but we don't gain anything from the referrals we make. So let us get you to a specialist if you think you have TOS and let that specialist tell you yes or no. The docs that we work with are perfectly comfortable saying, nope, I don't think it's TOS. And we like those straight shooters. All right, so contact us. We can help. KK, mine was EMG positive TOS with hand muscle wasting, so I got the surgery done. Is the outcome of the surgery better when it is true TOS with EMG positive? So I can't answer your question specifically medically, and I think you're asking it in a broad sense. In the broadest sense, we like to treat entrapment neuropathies in general before we see muscle wasting. Because TOS is difficult to diagnose, that may not have happened in your situation. EMGs tend to be positive when there's motor nerve damage, which indicates more severe damage. I think that once you have the hand atrophy and the positive EMG, a surgeon has to go in. I think that's the prudent thing to do, assuming there aren't other risk factors. And you want to relieve any residual pressure, compression, or stretching of the nerves so it doesn't get worse. So I don't know that it makes the prognosis better or worse. You were where you were at the time the doctor decided you needed surgery. Okay, I hope that answers your question. Should your MRI, Deb asks, should your MRI be done with contrast and hands over your head? I was hands down with no contrast dye. Yeah, so different people might do it different ways. Arms overhead, in my opinion, should always be done because one of the more common places to get nerve compression is in the costoclavicular interval between the rib and the collarbone. And you don't start to see that compression occurring in most cases until the arms are at least 90 degrees out from your body. And then above that level, it starts increasing rapidly. It's also what we call a stress test. I don't know if anybody here has had a stress test where you get on a treadmill and they monitor your heart and blood pressure. And over time, they start making you walk harder and up a steeper slope. And they're trying to push your heart to see if you get any lack of blood flow at a certain point or not enough oxygen. So you may get symptoms or an abnormal EKG. Blood pressure may change. And if those things occur, they'll stop the stress test. But the point is, if you get through the stress test, then they say your heart's in pretty good shape. So we do the same thing here. If we raise your arms over your head and we don't see compression of the nerves, the arteries, or the veins, we're pretty sure that you're not going to get that compression by doing anything in normal life. So in my opinion, it should be done with arms up. That's the way we do it. Now, we do it with contrast dye because we're looking for several other things. There are multiple items that we cover, but it does really help see the arteries and the veins in that area. That area is tricky because of the curvature of these arteries and veins. If you try to do it without contrast, you get some artifacts that can cause what we call a pseudostenosis, or something that looks like stenosis or narrowing, but it's not really there. So we use contrast. MRI contrast is generally thought of as very safe and much safer than other dyes that we use, like for CT. And we think it has a lot of information in our study. So you may not have had a complete study, but maybe they saw enough to make the decision that they had to go ahead. Or maybe they just said, well, the MRI doesn't show anything, but clinically we're sure. And so they went ahead and did it anyway at that point. Obviously, I can't read their minds. I haven't seen your medical notes. Thank you for the question. It's a really good question. All right. So we've had lots of good questions, really good questions today. I want to thank everybody. People are obviously thinking about this and putting two and two together, and from that, getting good questions. And I hope I've answered them well enough. Again, I want to thank toseducation.org for sponsoring and managing these talks. We really appreciate it that they go out of their way to educate people. If you search for TOS and education on Google, I think you find them number one. Our website is tosmri.com, and we are upgrading our website. We're adding new stuff. We'll have a blog coming up soon with fresh news. We'll also ask you, please follow us. We're TOS MRI on Instagram, on YouTube, on Facebook, on LinkedIn, I think. Just follow us, help chat with us, help like our posts, and help tell other people you meet who have questions about TOS to reach out to us. We hope we're being helpful to the whole community. And just like the other TOS docs we work with, we hope we're making the whole country better for TOS patients. So thank you. And I'm being interrupted. Lewis has another question. All righty. Do you recommend MR neurography or use it yourself? So there are places that do MR neurography. MR neurography, for everybody else listening, is a special MRI technique that shows just the nerves and gets rid of all the other tissues around as much as possible to make the nerves stand out. For a bunch of reasons, I don't think MR neurography by itself is good for TOS. The reasons are some of the following and some others. But number one, the established data for when MR neurography becomes positive is unknown. We don't know, can a nerve be damaged and show up as normal on MR neurography? And I believe that that's true. I think there's dysfunction in the nerves before that happens, but I have no proof of that. But nobody has proof to show that this is sensitive, meaning of all people who have nerve damage, how many show up with a positive MR neurography? And because of that, if you do MR neurography and it's normal, that leads you down the path of saying you can't have TOS because your nerves are normal. Well, the nerves look normal, but that doesn't mean that they are. Nerves are little tiny wires. They're microscopic. Some of them are just teeny, teeny, tiny. And an MRI does not have that resolution to see microscopically. So there are some artifacts associated with MR neurography that make it look brighter or darker when it shouldn't be. And if you just do MR neurography, you're not really addressing TOS. TOS is not a problem primarily with the brachial plexus. It's a problem outside of the brachial plexus that's pushing on the nerves or stretching the nerves or damaging them. So you need to see those outside structures cleanly. You need to see them in relationship to the MR neurography or the brachial plexus. Now, we use various techniques that have been used for years that can see nerves, that can see arteries, that can see veins. And it's something that I look at. I look at the nerves in as much isolation as we can get them, and the arteries and the veins as well. And, I think that part is always good to look at. In my experience, I've seen patients with really severe compression who don't have any nerve abnormality. So that's partly why I say I don't know the sensitivity, and I don't believe that it's a very sensitive test. I certainly don't believe it's specific enough to rule out TOS if the nerves look normal by themselves. And that's because I've seen normal nerves with severe compression in patients who clinically had severe TOS who got better after treatment. So I'm pretty convinced the MR neurography does not have to be abnormal in a patient who has TOS. I hope that answers your question. It's a good question. All right, unless we have other questions, I want to thank everybody for their time. And if you're watching this later and you can't ask your own question, reach out to us through tosmri.com. Go to the far right menu item, which is TOS Education, or just find the contact button at the bottom. There's a floating button at the bottom right, and you can contact us. Remember that at least March 29th, and we may have one sooner than this, but March 29th will be interesting because it's Dr. Jenkins and myself discussing cases that we've handled together, and we can go over the thought process of how we suspect TOS, diagnose TOS, and treat patients. All right. Thank you, everybody, for coming. We're really happy to present these educational talks, and I hope to see you real soon.